Good morning, Nyate Bene in my language. I'm honored to be here and present on the health inequities faced by Indigenous communities, and specifically my own Navajo Diné people. Next slide. The Navajo Nation is located in the Four Corners region of Arizona, New Mexico, Colorado, and Utah. And as appropriately taught, I need to introduce myself. Yate she Adriann Begay and she Next slide. I have no disclosures. However, I'd like to give credit to Drs. Don Warren and Dr. Sam Percy for some of the slides used for their work in social justice and health equity. Next slide. It's very important to remember that American Indians, Alaska Natives are born with legal rights to health services. However, at this point in time, American Indians suffer from some of the worst health disparities when compared to US all races. And the COVID pandemic has made these disparities even more visible. Next slide. So in order to understand why health inequities exist, specifically for Indigenous people, one has to be aware of the historical contents of federal health policy for American Indians. So the question, what is the legal basis for healthcare? Next slide. The right to healthcare, education, and housing are actually based on multiple treaties, executive orders, court decisions, and numerous other laws and acts. Next slide. Treaties are based on the exchange for land and resources. And according to a map developed by Aaron Carpella, a Cherokee from Oklahoma, more than 5 centuries ago, North America was all Indigenous land. Next slide. Today, treaties, federal policies, colonization, this landmass has been reduced for Indigenous people, also known as reservations. And currently, reservations exist in 35 out of 50 states in the US. Next slide. So Indigenous people have gone through traumatic experiences due to severing of their ties to their homelands. Even Euripides in 431 BC wrote, "There is no greater sorrow on earth than the loss of one's own native land," which brings up the topic of historical or intergenerational trauma and its lasting effects on the health status of Indigenous people. However, I am proud to say that many tribal nations have survived 200 plus years of federal Indian policy and 500 plus years of colonization, and that Indigenous people are resilient. Next slide. So what are tribes? They are sovereign self-governing nations in possession of treaties with the government deeding land in return for stated condition, known as a trust relationship with the United States government. Next slide. In 1977, a trust responsibility was defined as a legal obligation to protect Indian resources with provision of economic and social programs necessary to raise the standard of living and social well-being of Indian people to a level comparable to the non-Indian society. I can attest that has not happened. So where are these promises found? Next slide. Found in the Articles of the US Constitution, in the Snyder Act of 1921, in the Transfer Act of 1954, which helped establish the Indian Health Service, in the 1959 Indian Sanitation Facilities Act, which gave Indian Health Service the responsibility for the provision of safe water and sanitary waste disposal, which is critical for improving living conditions and prevent water and waste-borne communicable disease. However, we saw that this was a problem during the pandemic and still is a problem. It's also found in the Indian Self-Determination Act of 1975, and finally in the Indian Healthcare Improvement Act of 1976. Next slide. You know, each one of us, we need groceries, we need monies to repair our homes, our cars, our transfers. We need resources, which include dollars, equipment, staff, and space. However, according to the National Indian Health Board, the actual expenditures for Indian Health Service beneficiaries falls greater than 50% than recipients of Medicare, Medicaid, less than 50% for beneficiaries of the Veterans Affairs, less than 50% for the national health spending or private insurance, and less than 50% for beneficiaries of the federal employee health plans, shown by the FDI or the Federal Disparity Index mark, the same health program that federal employees, senators, and our representatives get. So in essence, inadequate congressional appropriations for provisions of these acts and laws. In addition, Indian Health Service falls under discretionary appropriations, which means the budget does not increase with inflation, does not increase with population growth, does not increase with new technologies, and the purchasing power decreases each year. In addition, it is subject to sequestration, so that at any time, if the annual deficit reaches a point that is unacceptable, the IHS budget can get cut. This is in contrast to the VA, which falls under mandatory appropriations and not subject to sequestration. The VA also receives advanced appropriations, so they get their money a year ahead of time. However, this is difficult for Indian Health Service because they are dependent on continuing resolutions if a budget is not passed. Next slide. So a whole different other lecture could be given on where Indigenous people find themselves now if we just talked about the phases of federal Indian policy. For now, I want to focus on the area I come from, the Navajo Reservation. This lies on a land base of 27,000 square miles, which is a little larger than the state of West Virginia. It has 5 health stations, 7 standalone ambulatory health centers, and 8 hospitals with ambulatory services. There are 13 grocery stores on the reservation, leading to food deserts. Other barriers are transportation. 25% do not have electricity. 20 to 35% of individuals lack running water. There's a lack of broadband infrastructure, which caused our children to be picked up by school buses and driven to areas where they could do their online learning in the school bus. And of course, difficulties with accessing health services. Next slide. There are outdated facilities like Gallup Indian Medical Center, once a IHS flagship as a national referral center for Indian Health Service. Built in the 1960s, the cost for the upkeep is high. Next slide. During the pandemic, all facilities, including Gallup, went under major changes to address the influx of patients. On the south side of Gallup, there were two outside pediatric clinics that were transformed to a low acuity ED space. An DMAT medical tent was established so that was turned into an outside emergency room triage area. And weeks into the surge, a mobile critical care tent was brought in to address the volume of high acuity patients presenting. Next slide. So COVID-19 exposed the glaring disparities experienced by many Indigenous people, including the Navajo. Multi-generational homes, lack of running water, difficulty accessing healthcare services, the lack of resources, and trust issues all played a role in the high rates of infections, hospitalizations, and deaths. We talked about the need for clinical trials. Trust issues were evident in the early weeks of the pandemic when Navajo people were hesitant to enter into Johns Hopkins study for the Pfizer vaccine. Many Navajo people recalled the era of the 1970s when forced sterilization occurred to our Navajo women. Next slide. For the CDC's COVID data tracker, American Indians shown by the mustard line showed the highest weekly cases of COVID per 100,000. However, by the inset, you'll see that just in early December, our monthly cases dropped below the national non-white, non-Hispanic population. Next slide. As far as deaths per 100,000, American Indians had the highest rates up until early December, and just recently have dropped less than the non-Hispanic white population. Next slide. As mentioned during the surge, many facilities on the reservation underwent changes, and the Chinle Indian Health Service modified space into inpatient areas. But one of the primary goals, especially for Navajo facilities, was the emphasis on protecting our elders and the most vulnerable people, which is a major part of our cultural belief in relationships, called Ke. Next slide. The culture of Navajo people is deeply rooted in land we occupy, the language that we speak, the songs that are sung, the ceremonies that are done, and the prayers recited. Our beliefs in Hujong, health and illness, and our relationships, our Ke, is very important. Next slide. So our kinship system of Ke privileges us to have multiple relatives. In many Indigenous communities, we not only raise our own children, but we have the responsibility of raising the next generation. This is our belief and the way we should live. Next slide. So although my Diné people have suffered great loss to this virus, we always remember that it is with beauty again. And that this is what we call Hujong Nasli. Next slide. In this concept of hope and wellness, Diné people have been able to attain a greater than 75% vaccination rate on the reservation in hopes to live with the virus, which is also a living being. Next slide. Next. So as an influential community that I speak to today, we are all healthcare professionals in some way responsible for helping vulnerable people. Increasing our competence of the people we serve is important, but most importantly, hearing historical truths are difficult, but not made to hurt anyone and not made to make anybody feel bad. But it is only through truth that we can move forward. Next slide. Understanding and respecting these truths are crucial in elevating health status of Indigenous people. Most importantly, caring for others is a gift we have, and discovering the resilience of others is a blessing. Thank you.